In patient-oriented research, there's a multiplicity of individuals who have different ways of knowing, assessing, analyzing, and responding to the processes of healthcare and health research, but who can all bring important knowledge, expertise, and contributions to the overall improvement of design, delivery, and outcomes of care. How can people with lived experience add value to health research, and what are some of the things to consider when partnering with patients, families, and communities? This is episode 10 of Pep Talks, the Patient Engagement Podcast. In this episode, we speak to Nicolas Fernandez about the value of experiential knowledge in patient-oriented research. Nicolas shares his experience from both his professional background as an educator and from his experiential knowledge as a person living with chronic kidney disease and a transplant recipient. Paul Ferry first asked Nicolas to tell us a little bit about himself.
I did my PhD in higher education or university teaching.
Okay.
And so the minute I stopped, I finished. I defended my thesis and I got my little piece of paper. They contacted me through contacts. I got an interview with the Center for Teaching and Learning or Pedagogy at the Université de Montréal Center. So I started working with them, doing working mainly with medical education, and within the walls of that entity, Vincent Dumais and the people who developed the patient partnership movement and the Montreal model and all that, they sort of stuck me in because I'm a patient. I have a kidney transplant that is going to be 12 years old next week.
Well done.
And I'm pretty good. For all those people who are renal people, my creatinine is 119, which is quite spectacular, I think.
Okay.
I'm very proud of that achievement.
Excellent.
So that's how I got involved. I mean, basically, Vincent told me one day, hey, why don't you come to Ottawa with me? We have a meeting at CIHR. And it happened to be the meeting, one of the first meetings for the patient-oriented research framework, the SPORE framework. And then I got invited. I met the people there, and I got invited to participate in another meeting in Toronto to sort of really work on a straw dog that had been proposed, and so that's how I got involved pretty much in. And basically also because of my ideas about it. For me, I work in the field of higher education and adult education, and for me, this whole idea of experiential knowledge is it's key for a wide range of reasons, but in terms of, for me, patient-oriented research has a lot to do with experiential knowledge that patients have. Patients accumulated after by living with a chronic illness, and that experiential knowledge is really a wealth of knowledge that needs to be exploited and needs to be brought to the table.
Yeah, that's interesting. We've talked to a few other people with backgrounds outside of health, and especially like in social science and education. So do you want to expand a little bit more on maybe the intersection between experiential education and patient-oriented research?
Sure. Well, I mean, patient-oriented research is, it's a kind of research, and research for me is an activity that produces new knowledge. Generally, we tend to see research as a sort of a complicated sequence of methodologies that are put together. A research question is developed, and then you get some kind of answers to the questions that you ask. And very often, it's always been the case. I mean, we've always used experiential knowledge in many ways, but it seems to me, and this is certainly something that I contributed when we were working on the SPORE framework, is that patients' lived experience with health care issues, with their chronic illness, with health management, is a very specific kind of knowledge that has to be included into the health equation. So basically, health research equation. So when you're discussing health research, you're discussing ways to reduce bias, let's say. You're discussing ways to quantify things. You're discussing ways of measuring things and sort of contrasting and verifying some kind of statistical relationships. But you should also be concentrating or thinking about what are the different kinds of perspectives that we can have on this very same health problem. And those, the more perspectives you have, the more your outcome, your research outcome, will have a chance of having some kind of positive impact on health outcomes, care in the clinic. So it's just a way that every discipline has their own sort of blinkers on, and biology has their own blinkers, and chemistry has their own blinkers, and so on. And so by including patient experiential knowledge, you're adding another set of blinkers, okay? But you're blending all that with another source of very useful and very rich information about what it is to be someone who has an illness, and what's it like to manage that illness, and to receive care, etc. So those are all very important pieces of information that we need to include, I find.
Yeah, no, I do find bringing in as many different perspectives into the world of patient engagement and patient-oriented research is really helpful for helping to understand what we can do and what's going on.
Yeah, I think so. Yeah.
So could you tell me a little bit about some of the projects you've been working on recently?
Yeah, sure. So I guess I've been working on a number of levels and fronts. I guess I'll start with the highest level, which would be the Standing Committee on Ethics of the
Sure.
Standing Committee on Ethics is this sort of consultatory, or what's the term that they use? But actually, we inform the governing body of the CIHR on any issue related to ethics in research and health research. So it's a group of about 10 people, most divided. Some of them are ethicists,
okay,
career ethicists and very, very well-known people in that field. Some of them are clinicians. Some of them are people, scientific directors of the CIHR, and there's some student members as well from the different. They try to have also a geographical representation. So there's people from Newfoundland to BC.
Okay.
And also there are 2 people who are public representatives, basically. And so they've been the chair that I occupied, or have been occupying, and will stop occupying as of June this year, has been one of the patient advocate from Quebec. And so that we discussed, and so there's been a lot of discussion in the past couple of years at the committee as to what exactly is the role. Obviously, we are assisted by the Office of Ethics, the Ethics Office at CIHR, who provide some of the basic operational capacity. When we need to do a project, or investigate some kind of question and so on, the Ethics Office comes in support of us. But we're also we have a double function in a way, and that's it's been a debate, but we inform the governing body about different ethical issues, and we suggest different positions that could be taken. And likewise, we try to influence them with regards to some specific ethical issues that we think are important and that need to be brought to their attention. So within the CIHR, the Standing Committee on Ethics, a couple of years ago, I started I participated in this working group with the director of the Ethics Office, Madame Geneviève Dubois-Flynn. We developed a guidance document for researchers, or actually it was a guidance document for ethics review boards, with regards to the ethics of patient engagement in research.
Okay.
So the working group was also made up of very well-known people in the ethics field, like Michael McDonald and Don Willison, as well as representatives from the Indigenous community, like Dr. Alexander King, and from Kathy Woods from Manitoba, who I knew from CanSol, and we had also Jean Miller from Alberta, which I think you might know. And so together we developed this fantastic document. I think there was a need for it. A lot of people, a lot of ethics boards, in Canada, were wondering, well, what do we do when we have a research project in which patients are are going to participate not as subjects or people that are going to be receiving some placebo or not placebo medication, but actual participants in the project itself. Like they're going to be conducting some of the research, be it determining priorities or doing background. Doing writing or interviews. Most of them, we're doing interviews or focus groups, but taking a sort of participatory role in ethics in the research project. So there was a sort of a very well identified ethics gap with regard to that. Like what happens when the patients are part of the research team? And so we developed this document, which is available or will be soon available from CIHR.
Yeah, I think I'm looking at it right now. So,
and I think the main thing about that document, which I think was really which I'm very happy about, let's say, is that we sort of expanded the basic issues of ethics, of research ethics. Traditionally those issues are, confidentiality, conflict of interest, and protection. We're gonna, no risks. You're not gonna be risking anything by participating in this research project. But we've expanded that with two more other concerns, which I think are very important. And one of them relates to power imbalances and participation, like integrating different people from different walks of life into the research project. So that becomes an ethical question when, because very often if you're a patient and you don't know anything about research, then tendency is that you'll be excluded. So it becomes a bit of an ethical question. And the other is the respect, the integration piece, but there's also the respect of the opinion and the knowledge that other people bring. And I think that's, in my mind, that's a key contribution, because it means that it's not only knowledge that is sort of quantified or verified or evidence-based, that it has to be listened to and respected and taken into account, but it could also be experiential knowledge, or what we could say, lived experience with an illness. And I think those two issues are very, very important with regards to POR in general, and with regards to the ethics piece as well. That ethics is not only just to protect researchers from possible libel or suits or lawsuits, but it's also meant to protect the participants in the research. That could be of different backgrounds and different. One of the issues with POR, which is always there, is the fact that patients are generally not recognized by institutions, or they don't have any academic positions, and so it's hard for them to fill out the common CV on this, which is required for research projects. So that's one of the challenges. Another challenge is compensation. Researchers, traditional academic researchers are paid for. They have a salary for doing all these things. How about patients? And that's also, it's a very complex issue, because some patients are don't have a salary, can't work because of their conditions, and they have they rely on welfare or things like that. So by making money off a research project, they can get some money docked off their welfare checks. And so there's a whole wide variety of issues that are generated just by the fact that patients are contributing their valued experiential knowledge to research projects. And that has to be, it has to be recognized. It has to be, in my mind, it has to be compensated for. The question is, how does the system, the way it works, the way it currently works, allow for that? And what are the changes that can be brought to the system to allow for patients to be compensated in some way, or recognized, or given some kind of retribution for the work that they're producing?
I guess a follow-up question about that would be, one of the things that we do at the Patient Engagement Platform in Alberta is field questions from researchers. So other than to read the entire document, are there one or two things that you might point out from the ethics guidance document that they should consider first?
I think we went through, what we did is we used the traditional research cycle. And so it's really meant to be sort of a guide for researchers and patients when they're working out things together. And in that approach, that allowed us to, for every stage of the research cycle, to identify some of the key issues and roles and and produce and provide some suggestions as well as some links to documents that might help illuminate some of the questions for people. So that's the first thing, to sort of look at it in that way as a sort of guide that, with regards to whatever stage they're at in their research project, they can look at what are the ethical issues that are most salient at that time, and ways to sort of attenuate their effects or handle, better ensure that that everybody is respected and that everybody is comfortable. Another point that I would certainly point, and this is something important for me, is just the shifting in paradigm. I mean, the diagram that is presented, I don't know the page number, but there's a diagram where we have the new ethical issues that come up. Some of the ethical concerns are also indicative of a need for a paradigm shift in terms of how research is seen, the goals of research, and the kind of approaches or the way knowledge is to be treated in research. POR, SPORE, the basic tenet of it is that in the ultimate picture, ultimately, SPORE should be changing or improving health outcomes for Canadians. And in order to do that, we need to really harness research to doing that. And I think in order to do that, in order to diminish the gap or the valley of death, as sometimes it's called, the gap between research and actual clinical outcomes, this is where experiential knowledge comes to be very critical in terms of, in all aspects of understanding of the reality of life with an illness, of translating knowledge so that it can be useful for people, and of actually enacting change, and also in measuring its impact on health outcomes, on people's lives, etc. And I think those two new ethics concerns really point to that, really sort of underscore that need to expand research beyond just I go into a society and go into a community. Let's say I do surveys, I collect data, and then I come back and I publish, and then I recommend this medication for let's say I'm being very very obviously it's not exactly like that, but I mean what I mean is that research and its outcomes can be a lot richer if we include that experiential knowledge. And in order to do that, we need to have that ethical framework with those new concerns that allow people to share their experiential knowledge, their experience, their insights in a sort of protected way, in safeguarding that no one's going to laugh at them, for example, on a basic level, but no one's going to laugh at them. On the contrary, it's going to be very valuable. That patients that might not be be at ease with researchers might sort of censure themselves and not say things that could be proved, that could be very important to know. And this is especially true for community-based research, and I think indigenous-based researchers are very, very, very sensitive to that, as they should be.
For sure. So beyond the Standing Committee on Ethics, were there other projects that you've been working on? Yeah,
the other thing that I'm very proud of that we did was the training. The training and mentoring committee at the CanSolve Chronic Illness Network. We developed 5 training modules. At the beginning, I keep saying modules, but they've become sort of training branches, because we sort of to work on the representation of what this means. Like, it started off as a curriculum, right? We're going to do module 1, module 2, module 3, module 4, module 5. But now it's a tree where they have different branches, and one of the core branch, or maybe the trunk of that tree, is one training. It's a training pathway developed by Helen Robinson Settee and her team at IPERC, the Indigenous Peoples Research Committee within CanSolve. They take people through a sort of a sensibility at first, and with regards to Native Indigenous issues, but also just a different way of approaching research, which is based on the knowledge that elders have and elders can share, and based on really tackling community issues, but in a traditional way, in a very sort of anchored way, in a way that makes sense for them, that doesn't alienate people, et cetera, et cetera. So that's the one of the core learning branches in our curriculum. The other, one of them, which was my contribution, because I'm I work in teams and collaboration. That's my field, let's say. Was the tools for patient-oriented research. So the basic communication and teamwork tools that are needed, like for example, a skill inventory document, and some tips on how to run meetings, for example, and how to make information flow within the research team. That's something I think that was very useful. Then we have another branch, which is a storytelling branch.
Okay.
Storytelling is a very human thing. Anybody, everybody, and this is true because we all spend millions of dollars going to cinemas every year. We love stories, and stories has been a very human way of sharing information. And so this module is geared for patients to learn how to practice and learn how to tell their story as of a patient, and also for practitioners, for clinicians and researchers to know how to interpret, how to work with those stories. So that's also a very important part that we felt that. See, and I mean, I hope you're getting with the description of this curriculum sort of our view of what patient-oriented research should be. There should be ways embedded within patient-oriented research to capture all that experiential knowledge from people. Capture it, work with it, make it go forward, and make it useful for understanding some of the health issues that we live through and that we need to solve, we need to tackle. The other module, there's another module which was done by my colleague who co-chaired the committee with me, Ruth Sapir-Pichas, who was a nephrologist here in Montreal, was on health research, kidney health research in Canada, it became a website or a sort of online tool for training on the basics of what kidney research is all about. So it's and the last one is led by one of your colleagues, Selena Alou in Calgary. Is on knowledge translation, and she did a fantastic job of getting. So her thing is integrated knowledge translation. So, and she kept repeating it, and I think she's absolutely right. Knowledge translation starts from the beginning, from the first dream of a research project. There should be knowledge translation. It makes total sense with POR, of course. So I think that curriculum or that sort of learning tree, as we like to call it, I hope it's gonna make people think and make people sort of learn a lot about how to come together to discuss health issues and to find ways to investigate them in a systematic, scientific way. I'm saying that we do science. Science also includes qualitative data, and experiential knowledge is a qualitative data that can be incorporated in health research, just as quantitative data can.
So what would you say then excites you most about the world of patient-oriented research and patient engagement?
I think for me, what excites me the most about patient-oriented research is the potential it has for transforming health research. I think health research is at a point now where there's a multiplication of morbidities, or what people call comorbidity. There's a complexification of the health issues that are out there that are becoming more and more prevalent all over the world. And current situation with the pandemic is an example of a health situation which we have no control over which everybody's scrambling to get some kind of handle on. By the way, my colleagues here in Montreal have been greatly solicited by the ministry. My colleagues, I mean by the CEPP, the Center for Excellence in Patient Partnership with the Public. They've been solicited. They've been called upon by the government, by our provincial government, to provide a lot of input into some of the decision making with regards to how to deal with the pandemic. On an ethical level, on a, for the palliative care issues, that's for surgery, for community. They've been building a community of patients to be able to support the patients that are in isolation. They're dealing also with the workforce shortages, which are, epidemic in this province. I mean, the long-term the long-term care facilities are severely understaffed. And that's where most people are dying now. So it's so patients have been very much involved in that recently. In these past couple of weeks, patients have been called upon to provide ideas, opinions, etc., to combat this. So that's one of the things with regards to health issues that they're becoming more complex. And also, it's not just a question of biomedical issues. Health is not just a question of what your body does on a physiological level. It's also what happens to it on a psychological level and on a sociological level. In that sense, we have to expand health research beyond just the biomedical level. Is my, so to say, crudely, and I think a lot of people would agree with me, I'm sure. And I think patients are uniquely positioned with regards to those two levels, of the psychological level or the psychoaffective level, where we need, care. For example, one of my issues that I work a lot with my interprofessional teams that I'm doing research with is the divide between cure and care being this sort of, basically, according to Joan Tronto, one of the researchers in this field, care is a way to maintain and repair the world around us to make it a better place to live in, essentially, is that. And that, if you take that as a research object or something that you want to do research about, and something which I think will lead directly or more effectively towards enhanced health outcomes, then you need to have this experiential knowledge that patients have. You need to have sort of this broader spectrum of data that can come in and influence some of the research projects or the health research, to make it a lot more effective and a lot have a direct impact on people's outcomes. Because, I mean, that's, the basis of community-based participatory research, is that, if you want to study a population, the best way to do it is by getting them involved, because that will guarantee that some change will happen. And I think patients, when they get involved in patient-oriented research, first of all, they want outcomes, right? They want to know what the cure for kidney disease. They want to avoid their kids having to go on dialysis. It's simple as that. And so that's what CanSolve is about. We spent a lot of time trying to figure out ways that make life easier for patients. So I think that's what gets me excited, honestly, is that sort of expansion of what the research enterprise could be in health. From not just biomedical, physiological phenomenon, but also social and psychological phenomena. And also, I mean, I take ownership of that, because I'm also an educator, so that's my field. I'm in this business because I love human development, and I love people. I love to see people learn new things and become who they want to become, or who they are. Sometimes, the old Platonic idea of becoming who you are. That's what we're here for.
Yeah, no, I mean, I have some background as well in adult education. And I think one of the interesting things about working in patient engagement for the last year for me has been seeing some of the growth in some of the patient partners that we worked with.
Yeah, I saw that in CanSolve over 5 years. And they're not, first of all, the relationships between the doctors and the patients was amazing. I mean, at the first meeting we had in Halifax back in 2016, it was Dr. So-and-so, and this is Mr. So-and-so, and this is Dr. So-and-so, and so. And even we were separated in 2 rooms, doctors and patients. But rapidly, I mean, the year after, in our annual meeting, it was, hey, Mike, this is Tom, this is Kathy, all those differences just melted away completely. And that was a huge, from a human perspective, I mean, that's fantastic. It's just, and you see that everybody wants to work together. They want to learn from each other. And that's very, very human. I mean, in a time, where we need to stick together, I can say that we love to stick together. And then some of the dividing factors or the dividing the forces that are dividing us are sort of can be melted quite easily actually, when you think about it. And it's just that's also part of what we're trying to do, sort of reduce that sort of division between health professionals, researchers, and patients, and so on.
Mm-hmm. So if you could give advice to researchers who might not have ever worked with patients or community members on projects that they've done, but if they wanted to get involved in patient engagement, what advice would you give these people?
I would, yeah, it's a good question. That's what we used to do it all the time. I think the key issue is, first of all, remind yourself that patients generally, not all of them, but generally, especially the ones who want to do research, are very much aware that you've devoted your life to research in a particular field. And in my case, the researchers who do research in nephrology have devoted their professional career to finding out more about the kidney. Mm-hmm. So from the start, patients are thankful. I mean, they're scared. They might be scared. They might be shy, whatever. But as a basic premise, if you've devoted your life to researching whatever kidney disease or diabetes or whatever, it's a major thing, and patients are, on the whole, very cognizant of that and very grateful for that. That's number one. The number two is not everybody is on the same wavelength with regards to what is important in research, and I think you have to be open to at first patients, not knowing what to do either. So you don't know what to do, and patients don't know what to do. There has to be a will. Where there's a will, there's a way. So if you really want to do patient-oriented research and you want to have patient partners in your team, everybody can contribute. And so the difference is that some people will contribute things that you might not think important, or you might not know what to do with. But other people will contribute things that might make sense to you. So I would say, start, find ways of making meaning meeting your patients, or finding common meaning with your patients. What does it mean for them to do research? What is it? There's a whole, of course, there's a series of technical issues with regards to funding, with regards to, that's going to determine, it's going to have an impact, obviously, on the relationship. There's also an issue with regards to patients in terms of their availability. They might not be available all the time. They might be having to, step back for a while to deal with some health issues, etc. But on the whole, it has to be a conversation, and it has to be a two-way conversation. And if a patient, not all doctors or health professionals want to do research. Well, it's the same thing with patients. Not all patients want to do research. Some of them would rather not, and would rather stay away. Others are curious, so they'll start by whatever. They'll start by getting consent for patients in the waiting room in the hospital, for example. Some of them will review documents that you have that you'd like to have the patient perspective on, etc. Mm-hmm. But that there's an evolution. I mean, there's one project, as we all know as researchers, there's one project, and there's another project, and there's another project. So it's a long-term relationship, I guess is what I'm saying. And that long-term relationship, you can build it. It doesn't happen automatically. You have to build it. And just remember that patients are going to be grateful for the fact that you are doing research in a field that is important for them. And patients are, first of all, they have ideas. Yes, they have agendas. Sometimes they want to do things. But patients can really move your project forward. And we saw that in the projects of CanSolve, where patients very often contributed significant parts of the evolution of the project. And they made the project go in different ways that at first researchers didn't suspect. So, and also I think another idea, which is becoming, for me, more and more clear, is that patients are not looking to become biostatisticians. Mm-hmm. Patients are not looking to become, interview takers or they may be they're interested in that, but there are already people who do that. Yeah, will bring something different, something new, which will be reaching out to communities, for example. they're going to be very much involved with knowledge translation. They're going to be involved with, they can be presenters of your research project to different audiences, etc. There are myriad ways that patients can be involved, and not necessarily in the ways that you think. I mean, they're not going to, as I said, they're not going to be research coordinators. They're not going to be biostatisticians. They're not going to be qualitative data analysts, et cetera, or statisticians, or the sort of traditional roles in a research project.
Mm-hmm.
And so, part of the guidance document from the Standing Committee on Ethics could help you in that, finding roles for the patients at the different stages of the research project.
It's a very similar question then. If there's anyone listening who might be thinking of getting involved as a patient partner or patient researcher for the first time, any advice that you give to them?
I think don't despair. It takes time. Remember that everybody. I've sat around the table with a lot of researchers, and at first, researchers obviously are just as wary or scared about what patients might bring or might do. They're not necessarily used to dealing with emotion as patients are. We are. That's what we're built for, pretty much. People who have chronic illnesses. We went through a lot of things, and so we're a lot more versed and competent in managing emotions. So we have to be careful with our partners, with our research partners who are not. And so be patient and I know we are, but be patient and be open to hitting sort of spaces, or reaching spaces with your researcher partners in which you can talk from as a human to a human, or a person to person.
Mm-hmm.
Try to look for ways in which you can sort of open up the field so that it's not just about the research project, but about a bunch of people working together and having a beer, if you can have a paid beer as a patient, is a helpful way. I mean, you're humans doing a very human endeavor. Research is something that only humans do, as far as we know.
Mm-hmm.
It's an endeavor that is never ending. It's an endeavor that we are instinctively programmed to do. And yet, when we realize that there is no final answer to whatever we do, we tend to get discouraged. So don't get discouraged. Just follow your instinct and continue. And don't be, as a patient, don't be afraid to speak up. And especially, don't hide insights that you might have. With regards to the research project, with regards to how the things are going within the team, if you can, speak up. People are going to listen to you, and you might be surprised sometimes that when you speak up and you have conversations that might be difficult at first, it leads to a better space with the team. That's I think my comment for patients. Yeah.
Thanks, and thanks so much for joining us on the podcast today.
You're welcome. It's been a pleasure.
Thanks so much for joining us for this episode of Pep Talks, the Patient Engagement Podcast. Brought to you by the Alberta Strategy for Patient-Oriented Research, Patient Engagement Team. Special thanks to Paul Ferry, Sadi Ahmed, and Sandra Zielinski for their co-production. Make sure to subscribe to this podcast wherever you found it, and we hope you'll join us again for more interesting discussions about patient engagement in health research and healthcare.